So I will just share my screen now.
Yes, please.
Okay. So I'm going to speak on approach to acute chemical injuries and few basics to be remembered and some newer concepts I will share with you as well. So we know that the prognostic factors, traditionally we used to look at just the cornea, but now we know because of Professor Dua about 20 years ago, it invited us to look at the limbus and our concept of stem cells came in. So we need to, in any grading, the previous grading was the Thoff's classification, where there was no stem cells were not known at that time. But now we look at the perilimbal ischemia, how many clock hours of whiteness are there around the limb at the limbus, and then classify patients according to Dua's classification. And of course, every patient of chemical burns, we must look at the eyelids as well, whether the lids are blinking, whether the lids are involved, because that also changes the prognosis. We know that in general there are acids and alkalis, and that the acids give you a very early ground glass appearance. Why does that happen? Because acids dissociate into hydrogen ions in the cornea, and the hydrogen molecule damages the ocular surface, and there is protein denaturation occurring. The protein coagulation which occurs gives you that classical ground glass appearance, and it prevents the acid from going deeper. So this is the typical, if you get a ground glass and if patient is not sure what has been put in, usually this is acid. The exception is hydrofluoric acid. So if the patient tells you it's hydrofluoric acid, though it's an acid, it behaves more like an alkali because of this fluoride ion. So the fluoride ion bypasses the barriers that acid is normally created and penetrates right through the stroma and into the anterior segment. So it behaves more like an alkali. Alkali's early appearance only deceive us because we think that the patient is not so serious. You see, the early appearance looks much better than in an acid. Why? Because alkaline substances are lipophilic. So we know that the cornea is penetrated by lipophilic drugs. We try and make drugs in pharma which are lipophilic. So alkaline substances being lipophilic can easily penetrate the cell membranes. Like acids, they dissolve into a hydroxyl ion and a cation, not an anion. Now this hydroxyl ion saponifies the cell membrane like soap saponifies fatty acids, while the cation interacts with the stromal collagen and the glycosaminoglycans or GAGs, and this facilitates deeper penetration through the cornea and into the anterior segment. So this causes even changes in the trabecular meshwork. So you can get a low pressure or you can get a very high pressure. Both are possible. And a lot of inflammatory mediators are released in this whole process as the collagens are being lysed. And this stimulates the release of cytokines, prostaglandins. All this can further increase the IOP. And infection is a big bugbear, especially in alkaline burns. So this is Dr. Dua's classification, which goes from a grade 1, which is very good, when there is no limbal involvement, 0 clock hours, to a grade 6, which is very poor, where almost the total limbus 12 hours is involved, and the prognosis becomes very bleak. As you go from grade 4 onwards, it becomes bleak. But please remember that this is a very dynamic classification. So when you classify, every time you see the patient, you must classify again, because areas which looked white of the limbus before might suddenly start showing pinkish because of your treatment. And so grade 4 can go to grade 3, or things can worsen with time, especially in an alkali burn. So from grade 2, you can go to grade 5 also. So this is not, it's not that you must classify once and forget it. You must continue to classify every time you see the patient. So you've classified. Now, what is the treatment? Emergency is copious lavage. Copious lavage means either you or your a good resident must clean the eye, wash the eye, not just a single 10 cc syringe wash and that's done, but it must be continued for at least an hour or so. You must continue to clean because a lot of stuff will then come off. If the patient comes early, you can do a paracentesis as well. And if it's a Lyme injury in our country and in Sri Lanka as well, Lyme is quite common because of the tobacco and the betel nut eating. So if there is any Lyme, solid Lyme particles, they must be removed. and you must double evert the leads to see if there is any lime particles. Don't be afraid to give GA as soon as the anesthetist gives the okay in a child with lime to look for this, because unless you remove all the material, this child is going to go worse. And whatever necrotic material is there, it allows polymorphonucleosides to invade, so that your necrotic material should be removed as soon as possible. If the patient comes 24 to 48 hours injury, of course you will wash. You must put all these patients on atropine, topical antibiotics because of the fear of infection, and a simple cheap drug, which is very less used, I feel, is vitamin C. Topical 10% ascorbate. If you have vitamin C injection available in your country, it is usually 10%. It is 500 milligram in 5 ml in India, and I'm sure it would be the same in Sri Lanka, which is 10%. So you don't have to dilute, you don't have to do anything. Just empty a tear medication lubricant bottle, and in that empty sterile bottle, pour this liquid inside and let the patient put it 1 hourly. So no dilution, no concentration. If you don't have IV vitamin C available, simply take a 500 milligram tablet of vitamin C. These are freely available and very cheap, and dissolve it in 5 ml of saline or water or lubricant, whatever you like, and that makes it 10%. So it's very easy. One tablet of 500 milligram dissolved in 5 ml of liquid, and you get your 10%. Put it every hour. And another thing which is very cheap, or it is free of charge, is the use of the patient's own venous blood. All of us have got 5 liters of blood within us, and we can use this. If you admitted the patient, then every 2 to 3 days, I bleed the patient and take venous blood from the antecubital vein and the elbow, and I inject it into the fornices. Every 2 to 3 days, when I see that the amount of blood is less, I inject again. And I will explain to you the logic of what I'm doing. So why vitamin C? Because the incidence of ulceration and perforation, which is so common in chemical burns, goes down drastically by this. Why does it go down? Because vitamin C is required by fibroblasts to make healthy collagen. I told you, especially in alkali burns, the collagenylysis is going on as a in a big way, and the new collagen which is coming in is weak because it's not strong enough, because the fibroblasts are not strong enough there. So it strengthens the fibroblasts and allows them to make healthy collagen. What about blood? Why am I stressing so much on blood? Because blood acts as a buffer. It dilutes the chemical, it separates the tissues, it prevents symblepharon formation because it's fibrinolytic. It acts as a barrier against further penetration. So blood has multi-purpose role. It contains anti-proteases. So it inhibits collagenase. Now, collagenase is an enzyme which breaks down collagen. So those poor fibroblasts are trying to form collagen, and here you have this bad, evil collagenase enzyme, which is which is trying to break it down. So if you put in enough blood over there, it contains anti-proteases or anti-collagenase. So it destroys the collagenase enzyme and allows the collagen to be made. The platelets which are there in the blood, so this is whole blood, this is not serum. So the platelets which are there in the blood, they change their shape. You know, our platelets are usually, if you remember your MBBS days, platelets are the cuboidal, are round shape. But these platelets become like amoeba. They grow pseudopods, as it were, and they hold on to the newly formed collagen and prevent it from breaking down. And they also fill in all the gaps on the denuded surface. So there are multiple roles of the blood. So I told you about giving the blood clot in the subconjunctival venous area. And at night, what I do is I simply take a syringe of the blood and pour it drop by drop onto the cornea, so that I form a blood clot on the cornea. Just keep the eyes open and just pour without touching. Just pour the drops onto the cornea in about 4 or 5 minutes. Because of clotting time, clotting factors, you'll find a nice clot on the cornea. Then gently pull the upper lid over the lower lid and let the patient go to sleep with a patch on the eye. Morning, you can remove it. So the blood is free of charge and has multiple uses. So if the patient is late a few days to several months, atropine, of course, will go on. Steroids is a big, many people are scared of giving steroids, but unless there is a melt which you can see, please put these patients on steroids. Ascorbate, the blood clots, the formation of the blood clot at night and iPad. These are all very, very cheap medications. This is a video, if it works, yes, of the, I'm just putting the blood clot, just you can see drop by drop onto the cornea. This is just, it's as simple as that. It doesn't take any technology. What about amniotic membrane? If you have access to it, it can be used in acute chemical burns. After thorough lavage, you've removed all the necrotic material, you can use it to cover the entire affected area. It has an anti-inflammatory role. It will be absorbed very fast. Unlike in cold cases where amniotic membrane can remain for weeks and months, usually in a few days to a week, it will get absorbed, but it reduces the amount of inflammation. It tamps down the inflammatory cycle. So the first paper was published in the AJO from the LV Prasad group, late Dr. M.H. Sridhar et al. About 2 decades ago. It just preceded Dr. Harminder Dua's classification of chemical burns. So how does it work? It has multiple role. I don't think we'll go into the detail of how AMT works, but it works even in acute cases. So don't be afraid to use it if you have access. Use it in every case of chemical burns. It's anti-angiogenic, facilitates nerve regrowth, acts as a bandage lens. There are several uses. Now, coming to some of the newer things, some of the lovely papers from Iran have shown the role of oxygen. Again, something which is very easy. We have learned about oxygen during COVID times. They've used oxygen therapy way back about a decade ago for acute chemical burns as well and thermal burns as well. And they found that when they did a blind study, when they took one group receiving 100% oxygen using a simple mask at a flow rate of 10 liters per minute for just 1 hour twice daily. So simple thing to do if the patient is admitted. You don't need ICU facilities. Just 100% oxygen, 10 liters per minute, which is not a very high flow rate, for an hour twice daily. And they found that the epithelial defects healed much faster in the oxygen group within 15 days versus 60 days. And the vascularization of ischemic areas occurred within 14 days versus 45 days. So this the corneas remain transparent. The vascularization goes down. There is better visual acuity and fewer complications. I have started using this in a few patients with really dramatic results. Of course, the usual systemic treatment and ascorbic acid systemically also does help. There are some newer treatment. We know the good role of doxycycline in various ocular surface disorders, and I would use it unhesitatingly in all my chemical burns as well, because the tendency to melting goes down. Of course, in the late stages, visual rehabilitation stage, you would think in terms of symblepharon release, stem cell grafts, and other mucous membrane grafts for keratinization. And the keratoprosthesis would be used, either the osteoodonto keratoprosthesis or what I use, which is the Pintucci keratoprosthesis. So to conclude, there are a lot of new things happening in treatment of chemical burns. Use of topical vitamin C, use of subconjunctival blood, and use of forming a blood clot at night, oral vitamin C, and amniotic membrane in the acute phases, as well as oxygen at a flow rate of 10 liters per minute for an hour twice a day. And I'm sure your chemical burn patients will have better results. I'm sorry if I've overloaded your brains. Not only have I finished, but I think I'm being the last speaker. We have finished the didactic talks for the day. And